invited Dr. Ritchey to come and speak, and I'm so glad that she agreed to do that. And the version I'm showing you, you may or may not be able to see my slide great, but we're always looking at these 4 M's of age-friendly health systems. Are you able to see those 4 M's on the screen? Awesome. Okay, and the 4 M's are what matters: medication, mentation, and mobility. And the idea is to provide really good care to older adults. This framework, based in the evidence, just asks us to assess and address each of these 4 M's for any older adult that we care for, no matter what setting, no matter our health profession, so that every older adult gets excellent care. And what matters really is the underpinning of all of that. And that's what Dr. Ritchey is going to be talking about today. This model of patient priorities care that she's going to share really helps give us a great framework and some wonderful tools for thinking about this M of what matters. So that's just the setup there. So Dr. Ritchey, you should be able to go ahead and share your slides now.
Yeah. I'm probably gonna have to do this.
Thanks for everyone introducing yourselves in the chat. It's so great to see so many of you here. I'll get started on introducing you while you're clicking there. Dr. K. Ritchey is a geriatrician who also has expertise in palliative medicine and spends some more time doing that, but and has a lot of clinical roles at the VA, but she is an assistant clinical professor with the University of Washington. She's based at the VA Puget Sound in Seattle, and she's the associate director for clinical innovation in the Geriatric Research, Education, and Clinical Center. And so does a lot of very innovative and important things that help improve the care of older adults on a system level, things related to fall prevention, and what she's going to share with you as another example in patient priorities care. So I'm really glad that you are joining us today and eager to hear what you have to say about this evidence-based excellent model of care.
Yeah, thanks. Thanks so much for that introduction. So I'm going to be sharing about patient priorities care. In case you're unfamiliar with what that approach or framework might be, it's actually a model of care that was developed by Drs. Mary Tinetti and Anand Nayak, involving eliciting patient values, goals, priorities, and then helping align decisions of care around those health priorities of older adults, especially with multiple chronic conditions. And so what we're going to be talking about today is not so much the framework for how we get to specific health outcome goals, but really talking about the alignment of care component to patient priorities care. So just so we're all on the same page about what do we mean by complex older adults. We oftentimes in geriatrics, you know, I'm sure as you've heard so far, we kind of think about pathological age versus chronological age. You know, there's this arbitrary cutoff of 65, which was placed by Medicare, but really what we're talking more about is kind of the pathological age that can happen mostly due to our health conditions and how those health conditions impact function and cognition or other layers of abilities. And so there's many different terms, you know, about what is exactly multimorbidity. But regardless, we're kind of thinking of people with many with many health problems and likely have some layer of disability related to that. Some of the challenges, obviously, in providing healthcare, and I don't know why it keeps doing this, so I apologize for that. But about some of the challenges relating to aligning healthcare with these individuals is that, you know, persons with multimorbidity, oftentimes there's a lot of uncertainty. There's uncertainty about what conditions are most affecting what matters most to people and what is the right treatment for, you know, potentially all those different offending conditions. In persons with multiple conditions, you know, there's also uncertainty about the benefits of harms of individual treatments, given the competing conditions. There's oftentimes no right best option. Oftentimes these are really just difficult decisions and just trying to choose what makes most sense in that moment. And often we're left wondering where to start too, particularly when we're thinking about aligning care. So to talk a little bit about what is patient priorities care and the approach for a moment and that framework, it is a model which aligns healthcare decision-making and care by all clinicians and patients and their caregivers with their own health priorities. It involves not only the health outcome goals that patients want to achieve, but also their preferences for healthcare. It's a model of care that elicits what matters most, which is in that kind of first step, in that first box, and the values that are driving potentially particular goals a person has for themselves. And then how do we align care, which is that second box, to help that person achieve those goals, again, connected to what matters or those values. And so what we really are going to focus on today is that second box there. And so hopefully with this conversation that we're having today, I'll give you some strategies on about how not only do we take what we, learn about what matters most, but how do we potentially think about ways to align care. So we're going to start with a person and kind of explain a little bit about what does this look like. So we're going to imagine a hypothetical patient. Her name is Miss B. She's a 75-year-old retired nurse, and her story is very typical, I think, for many older adults that we care for with multiple chronic conditions. She has atrial fibrillation, diabetes, depression, some reflux disease. She's had several hospitalizations in the past couple of years for a GI bleed. She also has heart failure with reduced ejection fraction, hypertension, sleep apnea, osteoarthritis, and osteoporosis. She sees a number of specialists, including you. Her main complaints during most of the visits include combinations of fatigue, dyspnea, pain, and urinary frequency. And she's often bothered by some aspects of her healthcare. She, finds it very difficult to take a diuretic because it causes her to urinate more. However, then when she stops taking it, she gets more short of breath and more fatigued, which makes it hard for her to do things like take her grandchildren to school every day. And she's also very reluctant to also sometimes let you know exactly what she is and is not doing at home based on the health recommendations you've given to her previously. So you take some time and you start to actually just sit down and talk with her and get to know who she is. And in this type of visit, you start with just asking how do you connect, and what is important to you? What are some of the ways that in your life, what activities give you joy in meeting? And so that's really kind of discovering, that what matters most kind of first part of this conversation. And you find out that connections to her family, specifically her grandchildren, are some of the things that are the things that continue to give her joy and meaning in her life. Then next, you kind of talk a little bit about, okay, well, what are some of the health outcome goals that you've right now feel like you're not achieving? And those specifically should be something that's specific, realistic, and actionable that will help them link them back to the things that matter most. So in her case, walking grandchildren every day to school a couple times a week is how she makes that connection to the grandchildren that's most important to her. But right now, as you kind of, again, find out further in the conversation, her shortness of breath or her urinary frequency are some of the symptoms that stand in the way of her doing that activity that matters to her, and allows her, again, to connect with her grandchildren in a meaningful way. Also with talking with her, you try to explore a little bit maybe of some of the healthcare management tasks, visits, or tests or procedures and medicines that she finds valuable or helpful. You also find the ones that are maybe a little bit burdensome or difficult for her to do for a variety of reasons, or maybe medicines that are giving her side effects that are unwanted, and also maybe prohibiting her from doing the things that matter to her. This is useful to know because it might be the reason for non-adherence and may help identify care that actually can be changed and modified. Even if it might not fit guideline recommended there, it's still helping her achieve what's important to her. And lastly, for Mrs. B, you find out that the side effects of her diuretic are actually problematic because it makes her incontinence worse and that she doesn't like to leave the house. And again, obviously leaving the house, walking her grandkids to school is what is actually important to her. And then lastly, through the conversation, you find out that really the thing that she wants to focus on today to help her achieve the goal that is most important to her is really that the thing that she wants to focus on is again, kind of addressing this incontinence issue so that she can get out and do things more often. So it's really what health problem, symptom, or other task is the thing that's prohibiting you from doing the thing that you want to do most right now in your life. And so what the nice thing about the one thing is that it really helps you kind of like start to focus on a specific issue in the midst of all of these things going on at once, right? To really kind of hone in and focus on care. And that's really going to not only just help kind of direct the care that oftentimes can seem overwhelming, chaotic, to some degree, just like kind of where do you start, and kind of really give you a focus, not only you as the provider, but also sometimes the patient too. It also helps you connect with the patient, I think, in a whole new way, because you're actually listening to them about what about all their health conditions is the most problematic, and connecting in a way that actually addresses, again, what are their goals of what they want to get out of their healthcare. Oops. So I'm going to move on to next slide. So just to kind of step back for a moment, Miss B's case exemplifies complexity of decision-making with multiple conditions. I think oftentimes we as clinicians, particularly in the context of primary care, are faced, and even specialty care, are faced with uncertainty about care. Again, uncertainty that rises with the balancing of multiple competing conditions. Where do you focus that day's, kind of focus most? Oftentimes we focus on the chief complaint. But let's move that chief complaint into more of like the health outcome goal today that you want to focus on, and how the chief complaint is prohibiting you from achieving that goal, and what are some of the strategies so that we can address the issue so that you achieve these goals better. So it's just kind of reframing that a little bit, right? And so again, in Miss B's case, the treatment for her one condition, her heart failure, exacerbates another condition, which is her incontinence or urinary frequency. Treatments that help one condition are affecting the others. So it's really hard, I think, on our end as providers from our perspective, to balance that. But if you put it in the context of her perspective and what is important to her, then it kind of makes it a clear answer. You're like, oh, okay, so let's try to maybe cut back a little bit on your diuretic to see if that helps your incontinence and or your urinary frequency to let you do this thing more often. And then checking in and checking back on that and seeing how it affects the heart failure on the flip side. So, oops, I'm sorry that my slides keeps going ahead. Starting with, so using strategies to kind of figure out how best to align care is helpful. Starting with the one thing is one of the ways I think that is best, and how to kind of align care related to a person with multiple chronic conditions. It helps, again, engage the person immediately. And it also provides the same target for many people that might be involved in that care. And then in the other thing that's, I think, really helpful about the one thing is that it's, again, the thing that the person wants to focus on most in that moment. And this can obviously change over time, which is okay. The big thing about patient priorities care and the framework of, care related to what matters, is that this is really an iterative process. Unlike maybe end-of-life conversations, even more palliative care conversations, which are really focused on a person towards the end of life or with serious or terminal illness, we think of these kind of conversations upstream and really kind of focusing on co-current care. So where are we now within the person's context of their overall care who have multiple competing conditions, and how do we align care on a regular basis? Again, kind of achieving those goals as those goals might change over time, but again, are always linked back to the values that make them who they are. The strategies for, again, there's multiple strategies for kind of like how to achieve health outcome goals. And there, through the work of, patient priorities care over the past 5 years, we've really elicited that there's 3 intersection strategies that are really helpful, but they're not, by far the only options or strategies out there for how to align care best. While the strategies might be obvious, we suggest, and I would suggest that, like, using them consistently or intentionally over time can just really help with how you, again, approach different patients. And particularly sometimes patients who have maybe complexities to their ability to communicate as well. But as you'll see on the slide, the strategies that I think have been kind of tried and true over time are first to use the patient's priorities as a focus of communication and decision making. Two, to develop some serial trials based on the patient's priorities to identify optimal interventions. And then three, to align decision making among clinicians with the identified priorities, particularly where they are in differing perspectives and recommendations. So we're going to kind of talk a little bit about each of these strategies. So I think first, though, it's helpful to note that the strategies are not always meant to be sequential or mutually exclusive. So you could probably start with like strategy 3 before starting with strategy 1. The other thing is you'll find that you might use a couple of them in different combinations. So as you'll see here in the diagram, right, some of the strategies can be overlapping or work together as well and happen simultaneously. And that they're not always going to be, again, in themselves. And sometimes it's not the only way to align care. I think there's many other strategies that can be happened outside of this. However, the clinical decision-making strategies can help patients feel heard and motivate them, if anything, to adhere to some medical plans that align with what most matters to them. And we'll see that kind of in the next couple slides. They also offer clinicians reassurance and anchor in the face of certainty and trade-offs. So for instance, in the case of Miss B, if we're going to cut back on her diuretic so that she's maybe having less urinary urgency, but could, again, negatively affect her heart failure and her heart failure symptoms. That's where it's kind of helpful to bring in the trade-off so that we're not just, kind of making a decision without the context of her other health problems. You're still giving credence to, again, some of the other things that are going on in her health history and in her health care. But she's part of the process of understanding what those trade-offs are and making a decision that goes along, maybe, again, affecting one health condition to support a different health condition. And then finally, the strategies help everyone, including the other healthcare professionals, family members, other caregivers, kind of get on the same page, especially about why we're doing certain things, again, that could negatively affect other health problems and why we're making that choice. Sometimes this happens, when we think about dose reducing or eliminating certain medicines, again, that might help, anticoagulate a person. But then we're choosing to do that because the bleeding and the bleeding risk or active bleeding is so problematic for that patient. And again, if it's done in a context where the patient is involved in that, they're very aware and knowing of the trade-offs, then I think that helps many others who are caring for the patient be more comfortable with some of these choices. So we're going to talk through a couple, again, like I said, strategies and give some tips and scripts. But just so you know, there's a really great decisional tool out there that is really helpful as ways to kind of, again, practice these strategies, go through these strategies, and have some maybe scripts, particularly for really complicated and challenging conversations that may arise. So one of the first strategies we'll talk about is using the veteran's priorities as a focus of communication and decision-making. So again, the main objective of the strategy is to move communication from disease-based interventions to focus on the person's priorities. So again, anchoring the conversation and how you present things in the context of what matters. So an example might be, again, I know you don't like using your CPAP machine, but I think it's really going to help you. Are you willing to try it if you see if it reaches your goal? And again, putting it maybe in the context of Miss B's main issue that she wants to address is her fatigue, linking, again, use of the CPAP machine that she previously has found unfavorable or has a lot of barriers to how it could, again, achieve her goal by eliminating the symptom is one way to kind of get around some of the things that have been hard for them to do, maybe. Again, presenting the trade-off, the decision-making within her priorities, it gives her power and control about what she chooses, as well as awareness and knowledge, so that she makes, again, the best decision for her. Another strategy, right, is kind of, and I apologize for having the word veteran. I'm used to talking to a crowd that takes care of veterans, but using patients' priorities as the guide to serial trials and starting and stopping or continuing of interventions. Oftentimes we think about this not only just in the context of things like a CPAP machine, but oftentimes medications. So for instance, I can give an example of a patient I saw yesterday in clinic, and there was a patient who had a lot of urinary urgency and frequency, and it was uncertain if there was an actual infection or not. But we thought about, let's try, because that was the most concerning symptom to that patient. It was like, let's trial an antibiotic and see if it helps. And if it doesn't help, then we'll quickly take it off and try something different. And that's an example of kind of doing serial trials. Again, is trying to figure out, again, what is the patient willing and not willing to do? You know, are they willing to do various medication trials, maybe exercise trials, physical therapy trials? And what do they find burdensome or not willing to do? And then again, focusing that around, you know, the thing that is most important to them, and like the symptoms that are preventing them from getting to achieving that goal. And then lastly, is kind of, again, the serial trials, again, like I said, with the one thing, maybe just move on because I know we're running short on time. But the last is really kind of thinking about how to align decision-making among clinicians with the priorities when there's, especially when there's conflicting recommendations. I think this is really important too, from a primary care perspective, when you're working with many other specialists that are involved, and is how to kind of acknowledge the uncertainty that, you know, that often arises around, again, competing conditions and medication particularly, or treatment modalities that might interfere with one another. One strategy is to, you know, have conversations and focus it again around what is most important to the patient, and how can we modify things in order so that we're addressing that and not really making it about, you know, again, guideline directed care, or about any one clinician's preferences necessarily. Again, when clinicians don't agree, it's often because one clinician feels it's more important to follow a particular guideline than another. And the other clinician might not feel the guideline applies to this patient, or the likelihood. You know, again, if we kind of come at it from a collaborative standpoint and think about negotiation and, or again, putting the patient first, it kind of helps with reconciling potentially differing kind of perspectives and opinions. So just to kind of wrap up, you know, I know that even with a lot of these strategies and example scripts that we've discussed, or that you might review if you go into the website, you know, decision-making and other challenges will arise. And so I think what's really helpful is to know that there's lots of aids out there to try to help guide some of this and how to practice it potentially. And so I just really want to, again, encourage, you know, kind of checking out the decision guide at patientprioritiestare.org. And then again, there's additional kind of references and resources for you all. And I hope that those are helpful as well. And happy to take any questions if there are any.
Thanks so much, Dr. Ritchey. I think we can start it off. There's some questions and comments already in the chat. An easy question is if you'd be willing to share your PowerPoint with the folks here so they can review back to it.
Yes, for sure.
Okay, so thank you for doing that. And then another question that that Carrie brought up, that Dr. Rubenstein brought up, is that I was wondering if anyone's created an EMR or EPIC template to help document these patient priorities care conversations It sounds like you've seen some on the website, but wondering if people are actually putting them into practice and how you get to them. So I don't know if you know about that, Dr. Ritchey, or if anyone else on here has experience with this in your system. If you're using something, please speak up.
Yeah, yes. So there are some of which are available and found on the website. The most readily kind of approved options are probably found on the patientpriorities.org website. You'll look under, I think, tools and implementation toolkit. And that's one way you can find them. I know that they're also trialing a slightly modified and updated EPIC. And I forget if it, and I know they're starting to trial some things on the front end of these conversations, as well as on the back end, to try to help align care. More of the effort has been put on, kind of front end, preparatory kind of conversation aids. And so patient facing documents that help them kind of like think about these things prior to coming into a visit, if that makes sense, versus on the back end on how to offer up communication and alignment of care. But what I will say is that within the VA, we've also come up with kind of like our own options as well, which may or may not be helpful to those out there as far as ways of communicating, preferences. And some of it is, I know within the challenge of EPIC, it might be where is there a focused place where all this stuff can go. And I know there's been a lot of thought about that. I don't think they've come up with an EPIC solution for that yet. In the VA, luckily, we are able to kind of put things into specific notes and post them in certain places, if that makes sense, so that it's more readily accessible to everyone, as long as you know kind of where to look.
Anyone else have area? Thank you for all of that. That's super helpful. Does anyone have an area where you document that? How are you doing this? If you found a way to do it well or at all. Feel free to unmute, or you can toss it in the chat if you're not able to unmute.
We have a .goc, so goals of care in EPIC, and you can kind of build that out. And then it does actually flow to a specific place in our EMR, but it's not used very regularly. And it's this would be an expanded use of it for kind of goal-aligned care, as opposed to, traditionally what goes there are DNR conversations, and we know that it's so much more than that. So yeah,
I do something similar. We have an advanced care planning documentation within our EMR, and I put it in there when someone tells me that they prioritize independence, or the conversation. Often what's missing in the EMR is we'll have a conversation about a post form or advanced directives or surrogate decision makers, but showing the work behind it and what really someone prioritizes. So I do toss it in there, and then I put it in all of my primary care notes at the bottom. It's something I carry forward so that if folks are looking at my notes, they can see that.
Yeah, and Carrie, I'm happy to connect you with some of those at Yale, or even ask them. I kind of keep tabs on what all they're developing as they're developing and piloting it in various. I know they're piloting quite a few things for EPIC. And I don't know if it's in Mount Sinai or where it is in New York, but a couple of the health systems over there and in Yale. So I can also kind of connect you as things kind of come along if you're interested in piloting them where you are.
Great. Dr. Braun, it looks like you have your hand up.
Yeah, I would just like to kind of pull a pin from a hand grenade and toss it into the conversation a little bit.
We're ready.
Yeah, awesome. One is to consider the type of intervention you're doing, and Dr. Bennett has this absolutely seminal presentation on preventative, the time lag to benefit of preventative screenings that really, I think, is a necessary template for us to consider when we're suggesting interventions on a preventative basis, but also, as we're talking about Mrs. B, right, issues of to what goal are we controlling her blood pressure? What's the utility of the diuretic insofar as when do we expect the benefit from tight blood pressure control to accrue to this individual? And does she need some sort of a hard look at the benefit of the treatment to her current circumstances? And I would say if you add a little bit of oxycodone or tramadol, a nightly tramadol, to the patient's med list, right? And at this point, you know, she says her most important thing is being able to walk with the kids to get them to school, right? And she feels she needs a daily tramadol in order to do that. Well, the medical system has also some requirements, right? And if you say the physician just should be dispensing tramadol without any kind of appropriate follow-up or supervision, and yet, you know, she would like to avoid medical visits because they take up time and make her unavailable to provide after-school care for her kids, you as a provider have a dog in the fight, and you need to be able to reconcile those competing requirements with providing what's most important to the patient. Thank you.
Yeah, I think the point you bring up that's really great is that I couldn't really touch a ton on is thinking about trajectory and prognosis. Obviously, you know, to some degree, these do overlap with goals of care conversation and advanced care planning for that reason, but then to some degree they don't, right? Because there's no one serious illness or terminal illness that is oftentimes like an instigating. However, we still can't forget about trajectory to some degree. So to your point, as far as time lag benefit, you know, and then thinking about that in the context of, you know, again, serial trials and stops and framing how things are standing in the way of doing what's most important. Yeah, definitely.